welcome back to another episode of The Jungle. With me today, I've got Dr. L, otherwise known as Lino. And, you know, I was fortunate enough to meet Lino recently. We started conversing back and forth. Lino has worked in the mental health field for quite some time. He coins himself as a scientist that also looks at factual data and then basically perceives his own idea. He's worked in the correctional correctional institutions, as long as the mental health field kind of meshed both those together. So he's pretty well versed in what goes on. So without further ado, guys, I want to introduce Dr. L. Dr. L, say hi to everybody.
Hey, everybody. How you doing?
So Dr. L, just tell everybody kind of who you are, what areas you specialize in, and what capacity you've worked in the correctional sector.
Well, I have about 25 years in secure mental health, and it includes maximum security psychiatric hospitals. I consulted to prisons, different units in prisons, mental health unit, behavioral health unit, special housing unit. Overall, as a psychologist, as a school clinical forensic psychologist, I have about 36 years plus. I think my perspective, and the reason for talking about it is that I think I have experienced old school and new school. Okay, old school in terms of I was a staff in a state psych center during deinstitutionalization, and that, and then the big push like in the 1990s. So I know what that's like. I also heard a lot of stories from old timers where regular state hospitals were farms and small industries and cities. And also the psych center was a small city. Also, I worked in 2 developmental centers for individuals with developmental disabilities, and they were the same thing. They were institutions, small cities, their own fire department, sewing crew. They're incredible. And then also on the other end, all the way on the other end with class action suits, the development of these kind of like behavioral health units in correctional facilities where, so class action suit because, inmates in a SHU weren't getting adequate treatment for their mental health. So it was, well, you know what, you need to develop these special units that balance safety and security with treatment and education and programming. So, I've been exposed to that on the other end. So I think, my experience is just a wide breadth of old school, current, and new thinking.
No, the fact that you brought up deinstitutionalization, that was a topic that I wanted to touch on. And for those of you that don't know, that was the program that Reagan introduced back during his presidency. And it was where we basically just started shutting down asylums. I believe it started in California, but made its way across the United States. By 2010, I believe, Runwell was the last asylum in the United States that was closed down in 2010. But, and we'll touch on a couple different points, but I do like that you have seen, like you said, the old school and the new school, because I want your take on, there's a lot of people that feel asylums and institutions should be brought back. I personally do feel that they should be brought back because there's too many incidents of mental health patients being mistreated, misdiagnosed, left to their own devices. And prison is not a safe place for schizophrenics or people with multiple even people with depression. You can't just throw those kinds of guys or girls in a cell and just leave them to their own devices. That's where suicide rate spikes, so on and so forth. So so you were in the field when deinstitutionalization happened. What was that kind of like for you? Because you would have been fresh in the field when that started sweeping the United States, correct?
So I started in '84. Just a quick funny story. So prior to that, I was looking for a job, right? I think I was still in graduate school. So looking for a job. So I went to a state psych center, and personnel, the woman behind the desk, was so nasty. I slammed, she's like, "It's in the book, go look in the book." I'm like, the book is like,
Yeah.
them, you know. And so I slam it shut. I never worked for a facility like that. So of course, 20 years later, I'm in that facility, and I'm like, you know, if I would have started back then, I would have retired earlier. But so I think in the 60s, I mean, you know, give or take 5, 10 years, whatever, you know, the push was, well, for developmental centers to put people in centers. Oh, you know, you need special treatment professionals. That's where you put people with developmental disabilities. In terms of psych centers, you really could walk off the street. I had people, I worked in acute admissions, but, you know, I kept contact with my colleagues in the back wards and things like that. So a guy would walk off the street and say, you know, I'm hearing voices, I feel suicide. Okay, come on in. You know, we'd had people that were like discharged. They walked 3 steps out the door. Okay, I can't handle this. I'm coming back in. I'm suicide. You know, like, so you know, they were a lot, the policy, the thinking was very different. It was, you know, kind of pro facility in a way, that, you know, it's called like an integrated setting. So you have, you know, professionals program where they reside, medical services, everything is right there. So you have a high level of integration, you know. So going to the community, what you start doing is disentangling that. Like, you know, we go to one doctor for our medical stuff, you go to another dentist, you go somewhere else for treatment, so on. It gets to be a little more complicated because you don't have people right then and there talking. You have the, you know, like one treatment team. So, you know, so that's the benefit, the real, when I think back to those days, I think back to that high level of camaraderie, a level of people right there that you could just talk to about someone, or, you know, hey, I just got this person, someone else knows them, you call them up, you start talking. So I think for people with real severe mental illness, real serious, severe, protracted mental illness, I think they really benefit from that level of integration, that level of facility. I think that's kind of clear cut. Trying to think. So, you know, my perspective is, you know, from a clinical and forensic perspective. So not only just, you know, the disorders that you would help people with, you know, treating disorders, helping them with better mental health, better well-being, but then forensically too, you know, over my, you know, over the years of practice that, you know, this, I started, you know, to expose to guys with arson, sex offending, severe violence, sexual murder, you know, it just kind of goes on in a sense. So it's like, whoa, this is, you know, you can have clinical disorders, but these other things on top just made it, you know, much more complicated. And it seems like over time, which is one of the things, you know, definitely want to discuss as a context over time in terms of mental illness. We had guys with 5, 6, 7, 8 axis 1 diagnoses, which is what you're actively treating. And then you have personality disorders, maybe neurological disorders, developmental disabilities, medical disorder, you know, like just, it just, you know, just layers and layers. So
I have to ask then, because I'm not well versed in in how asylums were run and the classification systems, so on and so forth. I am as far as the prison system goes. I've done research. I have been to prison. So when you're when you're classed into a normal prison, you are classed by the type of crime you did, whether it was violent, so on and so forth. Did they, and you were just telling me that in these institutions that you would have guys with sexual violence and crimes against children and violent, extremely violent crimes and arson, like you said. Now, did the institutions back then, did they classify these guys to say a separate housing unit where maybe these guys were held apart from like the less nonviolent offenders, or was everybody kind of just meshed in?
So institutions, I guess, are, you know, you have different types. So you have developmental centers for people with developmental disabilities. So the most famous developmental center is Willowbrook. So that's an example of that type of institution. You have correctional facilities, prisons, jails also, so that, there's that type. And then you have the mental health system, so you have state psych hospitals, but then also you had maximum security forensic hospitals or units in hospitals. So you had different, when you talk about institutions, at least 3 different types of institutions within a state. I would say, I mean, for correctional facilities, you have a little bit more of that kind of like screening, classification, profiles, and then placement. In psych centers, I mean, they would just kind of be with everyone in terms of admissions. So someone comes in, they have a problem, so they're admitted. You have to figure out what's going on. You try to, triage and treat someone and then get them back in the community. But if it's really protracted, then, maybe they go to like the secure unit within the hospital, or maybe then they have to go to like a back unit, more chronic unit. They may have a little bit of, kind of division between where they go, but not so much. I think the focus was, that the mental illness may have driven the criminal, whatever they were doing.
Yeah.
Although, if someone was that assaultive, I had a couple of guys that were that assaultive in a state psych hospital, they could be then transferred to a maximum security forensic hospital for treatment. So they're the only real, I mean, it's kind of a tough question. So in a maximum security forensic hospital, you have 2 types of units. Those guys that are not competent stand trial. So they don't understand about their charges. They don't understand the legal system. They don't understand how to work with their attorney, because of mental illness. It could also be because they're just not exposed and not knowledgeable. So they're placed in one type of unit that deals with that. Another type is the old NGRI, not guilty by reason of insanity. That's old, now it's not guilty by mental disease or defect. So these are guys that they really, because of psychosis, schizophrenia, depression, multiple personality, whatever it is, that they've committed a crime that they don't know that it doesn't conform to laws, it doesn't conform to, proper good behavior. They're not responsible because of that. So that's a very clear-cut distinction. But within, then you may have special programs for sex offending, for arson, maybe a special group for sexual murder. So, then it's more of kind of like a therapy. Not so much that they would be in a residential area that's just like sex offenders are separate from murderers or whatever, arsonists. They're all kind of together in a sense. So, correctional facilities, I think you have, my experience is just consulting, not so much working as much as, these other types of centers in correctional facilities. But, my understanding about you have just general population, and then you can have a mental health unit, and that can vary in the size of that type of unit, where if someone, a lot of disciplinary tickets, they're just, someone can see that they're not following the routine, they're being very aggressive, they're just disruptive, they're bizarre in what's happening, that, they can be screened and then pulled into a mental health unit. If they're really highly disruptive, highly aggressive, inciting others, and maybe pull them into a SHU, special housing unit. And then you have, in some prisons, you have these behavioral health units, that these are maybe the most dangerous people that have real severe mental illness. That, now, so the trend, newer trend since 2000s, whatever, is to provide program education, recreation, that it's called a good life. you're trying to provide a good life so that people can be better. So when they come out of whatever the institution is, that they can continue and live a better good life, as opposed to, being punitive or, they're in institutions, there always is a kind of not a punitive, but it has its good and its bad.
Yeah.
Whenever you're in the care of someone else, like the Stanford study, the prison study with Zimbardo about, even good students, good people that weren't sadistic, when you're kind of in a situation where you have kind of power over someone, and the expectations may be a little unclear, you're left to yourself to interpret rules and guidelines, you get stuff happening. And it's easy to kind of blame the staff, and there are some staff that are sadistic and psychopathic that work in institutions. Clearly there are. But sometimes it's the situation that they're in. Well, a lot more times, it's a situation that they're in, and not being maybe as supervised as it should be, like really supervised, where you're integrated in a treatment team, you get supervision and debriefing after you're assaulted, over and over again, or injured, that you have, a place to talk about that. So, so I think, overall, my perspective is that sometimes these situations are very complicated. It's a very difficult answer, like, was this good? Was that bad? Wow, it's complicated.
Well, I think you hit the nail on the head. It's not an easy fix and it's not an easy answer, because just of the sheer amount of mental health disorders that, the last study that I could even pull was from 2007, and it was 14.8 million people had some sort of mental health diagnosis. That's 14.8 million people. And then there's like this other study that goes on, like if just 50 beds were available, it's like 100,000 people could be treated, so on and so forth. But I don't think the general public understands there's just limited resources all the way across the board. So that's where you're stating programs and so on and so forth from somebody that's been in a correctional facility, and I've actually been in a psych ward and so on and so forth. It is, you guys are stretched thin. Those workers are stretched thin. The doctors are stretched thin. Resources are stretched thin. Beds. And like I said, the data is old, but beds to just get people in these facilities, the programs, everything is stretched thin, and you have budget cuts, and you have, it's just hurdle after hurdle you have to jump over. So it's no wonder that the mental health, it's no wonder that it has skyrocketed, but it's also, I don't, again, and I'll go back to this, but I just don't think correctional institutions are the correct setting for mental health patients. And going back to touch on what you were kind of talking about, with being integrated into programs. I know when I came home, I will say I witnessed several instances of people who had clear mental health disorders while I was incarcerated being pepper sprayed and maced and dragged out of their cell and put in spit suits and the whole time. And I've always, I don't like to think that I'm intelligent enough to understand what's going on. I don't always have the whole picture, but I've got a pretty good grasp on when I see something going on. I could dissect it and figure out what's actually, and you see these mental health instances and you see these guys where they're being beaten and they're being mistreated. And I was right next to a guy going through Lorraine at intake. It was me and my other cell, and he was banging and beating on the door, which is a very, in everything that I've read, that's a clear sign that there's some sort of mental distress going on.
Yeah.
They walked over, pulled his food door open, and they don't use pepper spray. They use bear mace, and he just lit the cell up. And I'm like what? Like, the guy's obviously looking for help. Now you've just bear maced the entire range. Like, there is other instances. You see these guys where at Lorraine, they have a top range and a bottom range. And when it was kind of overpopulated, so the unit, it was housing unit 4 that I was in, the bottom level also doubled as a suicide watch range. So it was the glass door. And then they put you in these big suits, like it's so you can't like choke yourself with and you have a guard that sits outside and the amount of people in tears, just distressed, people being distraught. And the whole time I'm sitting there, and that's instances like that were one of the main reasons I wanted, especially when you said you were in the mental health field, I wanted to have you on, because I don't think stuff like this is talked about as much, and the general public doesn't understand that since institutions have kind of gone by the wayside, this is it's what's happening in a lot of the correctional institutions. Brad, I told you I wanted to talk about Bradley Ballard real quick, and I've talked about it on another episode. I'm going to breeze through this real quick, and then I'll get your kind of take on it. I kind of already know what your take is going to be, but I just wanted it as a little bit of content here. So Bradley Ballard was an inmate at Rikers Island. He made a lewd gesture at one of the prison guards. She was a female officer. He wrapped a towel up, like kind of long, and was swinging it like it was his genital area. Just for that alone, he was locked in his cell for 7 days. He was agitated for 6 of those days. He was denied his medication, which was blood pressure medication. It wasn't like, hey, I got a headache, I need Tylenol or anything, or Meprazole. It was blood pressure and I believe insulin he was deprived of. He clogged his toilet as a protest, so it overflowed, stripped off his clothes, and tied a rubber band tightly around his genitals. And then during that period, and I actually went back and watched this video, and it shows over 6 days, guards continuously passing by his cell. Nobody would check on him. Nobody would look at him. Nobody asked him if he was okay. He was finally found on the 7th day, naked, unresponsive on his floor, covered in feces. His genitals were swollen badly and infected. He was rushed to a hospital and died hours later. And basically, this was just the big mainstream case that happened in Rikers, but I don't know how well. I know we're not going to talk institutions because I know there's like privacy, so on and so forth, but I know Rikers is notorious. I had another episode 4, a buddy of mine, he actually went through Rikers, and he said it was probably one of the scariest places that he had ever been. And he's been through the system, you know? Do you think this is, do you think in your experience, are issues like this more prevalent than what's being put out into the media? Or are they, I know, and this is an extreme situation. Like I said, his family was awarded, I think it was like 52 million from the city of New York. But do you think this is a more common thing that goes on? Because in my experience, I see guys get thrown. You start acting up in prison. COs aren't equipped. They're not well versed in mental health disorders. They don't know how to identify you, so they throw you away and lock the key or swallow the key for all intents and purposes. Do you think that's more common than what the general public realizes?
Again, a very tough question. Well, we probably could do a whole segment just on what the news reports.
Well, let me ask you this then. How do you think Rikers, and I can edit all this, so if this gets weird or whatever, I can go back and I can chop it up. You just let me know. I meant to tell you that at the beginning. Let me ask you, what would have been, obviously you and I know the correct way to handle somebody like that, but I mean, what he did really wasn't even punishable. I feel like that was maybe a instance of a guard just using extreme force, using the whole situation overall.
Well, it appears like that. It appears like it was very unresponsive to the crisis. It may have started behaviorally, whatever, but it sounds like it was very unresponsive, exacerbated it, and and had a tragic ending. I think that in the I'm not sure when there was push by states to really investigate instances of abuse. Internal, it's pretty much internal to systems, although you can have Office of the Attorney General then look into, I guess, more repeated cases in that case. So it does happen in institutions, all types of institutions. I'm not saying deaths. I mean, that does happen too. Institutions, I think, really do try to do a good job in investigating and trying to have corrective measures so that that doesn't happen. I mean, you don't want those things to happen. I can't say of all those cases across states, the ones that rise to the level and hit what threshold, but then now they're in the news. Usually the more sensational cases, hit the news. I know of politics where sometimes, certain cases or individuals were totally ignored by the news, but it happened, but then they may have redirected it to other cases and then that became, so, there can be a political piece to it. But I think that goes back to, let's say what's the best way to handle it, and that'll put a perspective on maybe what happens. So the best that I've seen is having correctional officers. Okay, you have a treatment team, so you have a person who has mental illness, has those needs in a special unit of, I don't know, can range from whatever, single digits to maybe 100 max. And they have a full treatment team with psychiatrists, psychologists, social worker, other therapists. They have, therapy related direct care staff and also COs that are part of the treatment team. So whatever happens, everyone meets together so that, what traditionally happens is that a treatment team doesn't include, kind of COs or other direct care staff that are providing treatment or oversight, so that they're just not maybe supervised in the same way. They're not informed in terms of what the current thinking is. Hey, this guy's going through a mental health crisis. This is the way we need to maybe approach it. What are the challenges? You talk it over, you come up with a treatment plan, a way to proceed, and then you implement that. Maybe you do more checks. That's the better way where it really works. But it's hard to implement that across. It's hard to even get individuals in those special units. There's just so much of a need for them. But then also you have guys that are antisocial and psychopathic and maybe, gang related who, kind of malinger symptoms to be able to get into these special units because they're easier time, more protected. So you have those where, you have to go out and screen people in the general population or whatever, saying, hey, is this guy malingering or their real mental health needs, and so that's the best way it works. When you have a lot of people, and the other thing is, as we know, the rules and procedures in a prison or a secure facility, wherever, it's almost like another presence by itself. You don't violate them, very clearly when you first walk in. Where you stand, how you stand, who you look at, don't look at, it's all like just pretty fairly clear. It's a presence, and the reason it's like that is for health and safety and security, that you rely on procedures. So things that get in the way of procedure, even now we joke around sometimes going in, like you get stamped. So there are multiple security stations, and you get stamped that only you can see it through a blue light. Or so I joke around, hey, I got a free drink in New York City with this, whatever. So I'd be joking around, whatever, and I could see them behind the thing that, like, we can mess you up. But, it was a joke, but even a little joke, you look at me like, you'd start growling at me, and it was funny. I mean, we just had that kind of, rapport, but you could tell it's like, don't be messing with that. It's kind of, they really, that's what makes facilities run particularly when you have people that are very dangerous. And a lot of things going on. There's a lot of moving parts to that: mental illness, gang violence, just also, an individual re-engaging in their crime, trying to set a fire,
Yeah.
offend against a female or male. You got a lot of things going on that I'm not saying, it's kind of an excuse. I'm saying that it's really very complex. And when you're, it's best to be highly supervised and debriefed and a lot of training and being integrated with a treatment team. That's the best. That really works.
Yeah, but with like we touched on prior, though, it's very hard to do that when resources
Yeah.
are cut, budgets are cut,
Yeah.
and I guess that's where the stalemate comes involved in all this. Is you have, I mean, obviously somebody of your background, you understand what it takes to rehabilitate, to work with, to make somebody successful, the treatment that's required, but all that takes money, and all that takes bodies, and it takes educated bodies. Not just, you can't just throw a mouth breather that works at a facility down the street into a doctor's chair and say, hey, here's the book of what's the NAMD or whatever it is,
DSM,
the DSM.
DSM-5.
Throw a DSM in front of them and be like, hey,
Yeah.
read this by tomorrow, and now you get it. Like, you just can't do that, and I think that's where the overall breakdown comes in, obviously. But so what would you, and I know I'm asking you very general questions, so, but what would you say? I mean, what's the next step then for correctional institutions, and maybe to get to the next level where maybe something, do we need to reincorporate institutions in the United States? Do you feel like that would be what's the next step?
Well, maybe if I can back up a second, because I wanted to just have a context, to go on to talk about, what works, what doesn't work. So my thinking is that correctional facilities have become almost like schools. In schools, you have a multitude of things hitting at the same time. Low SES, homelessness, food instability, maybe gang violence, community violence, separation and divorce and family. You get all these factors hitting in this setting, and sometimes it's very difficult to be able to manage that in a proactive way, in a very structured way. So it's a tough question about, yes. So in the 1960s, 70s, particularly 72, was the thing about, the criminalization of the mentally ill because of closing psych centers and, and the war on drugs. You had more individuals going into correctional facilities. But so before that, mental illness, I couldn't find data going back into the 50s and 60s till currently, other than just qualitative saying, yeah, it's increasing. Yeah, you're right. Mental illness rates are increasing since then. Like in the last 10 years, there's research that shows it's an increase in 13%. So I think there's no research that I could find that definitively says, well, closing of psych centers or developmental centers or other institutions have significantly and clearly funneled people to correctional facilities. So there's no data that says that. There's a lot of talk about criminalization of mentally ill and, oh yeah, the war on drugs. The war on drugs, I think, was clear about, a lot of people, drug-related offenses ended up in prison. Okay, so that's kind of.
And you also have the other, it was funny because I was and I don't talk politics, and don't take this the wrong way, but I always did appreciate Reagan. But then reading into institutionalization, I'm reading a lot of things where I'm like, I don't know if I really supported everything he did back then, like this maybe. I understand like asylums and institutions were like in a decayed state, but then there was this funny, it was, did Reagan create the homeless problem in the United States. And that, I think that plays into another factor of what you were just saying, because it's not only the war on drugs and the mass influx of people into penitentiaries, so on and so forth, but now you have a huge homeless problem as well. And not to cut you off, I just, it registered you were saying that. So I just wanted to touch on it.
No, that's an area to go into too. And so you have mental illness increasing prior to, or going along the same time as these other kind of closures and movements. And so to say that because of that, they really were funneled into correctional facilities in terms of, people with serious mental illness. Well, there was an increasing trend anyway. So chances are, and people with mental illness have a much higher rate. I don't know if, so I think it's up to 40% or whatever of finally being incarcerated, more so for minor crimes, not necessarily major crimes. If it's a major crime, then it could be, a state psych center, forensic hospital. If it's a major crime, the mental illness was instrumental. So, you have increasing rates of mental illness. You have those, people have a bigger probability, or 40%, at least up to a 40% probability of entering correctional facilities, and maybe just entering correctional facilities anyway, not necessarily because the mental illness is instrumental. And then you're in a correctional facility, that's going to cause, because the stress and everything that's going on, and exposure to violence and other things that are happening, cause mental illness symptoms. So I think you have a multitude of influences that end up with, okay, now you have a lot of people with mental illness in a correctional facility. So I think we like to look at certain closures led that way. And I think that, I've heard from patients when they were going to be discharged, they said, well, you know what, if I can't make it in the community, I'm just going to go steal something, whatever. I'll end up in jail or prison, whatever, and then they're going to take care of me again.
Oh,
I've place to stay,
I've met a lot of people with that mentality.
Yeah, they're like, hey, if you're not going to take care of me because you put me out, I'll just go do that. So that was very, very common. And also people, homelessness, one guy who just was mute and I thought was psychotic, and he was attacked by someone else who was really very psychotic and dangerous. And so I felt bad for him, and, took him into my office, said, I'm sorry, whatever. He started talking to me. I'm like, oh my God, this guy talks. He's never talked the whole time he's here. And he says to me, all right, you've been so good to me. I'll let you know. I'm part of a group of people that go throughout different states on the East Coast. And we have different months that we meet at different hospitals and other places. And we know who has the best food or whatever. And so this was this month where we were at the time, and he says, yeah, and he described the whole schedule. So I'm just trying to give you an example. You have a lot of stuff going on where people are trying to manage systems, not only maybe the victim of a system, kind of trying to navigate the difficulties or complexities of the system, but people who also use the system. So you have people who are homeless, and so yeah, you have a lot of mental illness, in a homeless population. So then, they're, because of, the mental illness, homelessness, they don't know how to negotiate with the police. They may not know how to negotiate with their landlords. They get into conflicts that ends up, being incarcerated, or, so you get these pathways where people then, end up. Well, the other thing that I like to think that this really factored in is that, in the, I don't know if it's the 40s or 50s, some people in the medical profession said that, in these institutions, we really have a captured population where we really could test out some different treatments and, medical treatments and other things. So there was a period of time where, children and adolescents, adults, really were put through horrendous treatment. The Tuskegee, syphilis study where they were, withheld treatment for syphilis
I
to see,
mean,
let's see what the course is.
yep.
So that, I mean, it wasn't rampant, but you had a lot of that going on across states. So, that's yes, the institution in that it's very integrated. You have everything right there. It's a protective environment. It can offer, and I've known people in maximum security hospitals, correctional facilities, developmental centers, really good people that got really injured and they just came back the next day. It's like you have your eye socket fractured by a patient who was like, well, first of all, I'm not going to let it get to me to show that I'm weak. And secondly, I have a job to do to take care of people. It's like I was just amazed over and over again the level of commitment. And I think that my experience was the level of commitment and dedication really attracted me to these special centers. So you have, some staff that are phenomenal. On the other hand, is there higher levels of abuse or mistreatment? Well, whenever you're taking care of others, if it's a nursing home or other, there are going to be instances of alleged abuse. It is investigated. There are corrective actions. There's education. Sometimes staff are fired that, really are abusive. And then I put on a registry where they can't get a caretaker position anymore. I think it was the 50s, Irvin Goffman was a sociologist. So he studied asylums in that day. They were called asylums. Now they're called facilities. So he says, well, the only thing I remember from that book was that, well, as the individuals who are, if they're inmates or patients or whomever, citizens, they got a little bit better in institutions, but staff got a little bit worse. So you had this kind of inverse, relationship kind of in a sense or result. So, some people really did very well. I think institutions are good for people that are the most dangerous, the most complex, the most vulnerable, because they're also vulnerable to abuse. And maybe sometimes even more vulnerable to being the victims of abuse and mistreatment than actually perpetrating further acts. So I think my own perspective is I think that's very clear that I think, a facility for the most seriously mentally ill and also dangerous, these facilities, integrated settings with the best small units, all the staff in a meeting, debriefed on what's going on constantly. That works really well. It does well.
Well, I have to agree with you on that only, and I'm just going to cut you off real briefly and share a quick. So at the end of my sentence, I remember I got sentenced to it's called NeoCap up here, and it's Northeastern Ohio Community Alternative Program. And it's technically an in lieu of facility. Instead of going to prison, you are sent there, and it's treatment plans. But my family was very adamant that I needed some sort of rehabilitation, some sort of program as well. So they lobbied to have me go there after my prison sentence. And I was so mad because it's to go from prison to be in a facility where it is structured as far as how often you can stand up from your seat and go to the bathroom, down to the second you're going to chow, the second you're getting up in the morning. But it's the same thing. It's treatment plans. It's you meet with your caseworker once a day. You go to 3 or 4 or 5 classes a day. It was very, and as much as it was structured, I learned a lot there on how to deal with my emotions, how to deal with my thoughts. You know what I mean? Like the change, I'm sure, or the class, I'm sure you're familiar with it, like thinking for a change, things like that.
Yeah.
That's what we did in that facility. And it was 3 months, and it was the longest. It was longer than the 2 years that I spent in prison. It felt like, because it was so monotonous and boring. But I
Yeah.
also have to agree with you. That's what's needed. Everybody all the way down the line, from the top psychiatrist, psychologist, it would have been a psychologist. They did prescribe meds there. I don't know, the director of the program, all the way down to the we'll call them orderlies, the staff that would just kind of keep an eye on everything all day. They had like 4 meetings a day. It was all hands on deck. Everybody knew what you were doing. Everybody knew what you were up to. Everybody communicated. And that, I think that was more beneficial in my rehabilitation. I mean, I've been home 10 years and I haven't had as much as a seatbelt ticket. And I think that was, that was more detrimental in me being reformed or getting my life back together and understanding like what I was doing, what was going on, than the actual 2 years in prison. So I appreciate you saying that, because, and I think you're onto something. I think you're absolutely right that even if it is in the jail setting, even if institutions don't come back, there needs to be more of a all hands on deck mentality. You don't just leave these guys up to their own devices. You need to devise a plan as far as, hey, he's violent, but we think he's schizophrenic. You know, we need to, and there needs to be treatment involved in all that. It can't just be, hey, he's acting nuts, we throw him in a cell, you know?
Yeah. Well, I think that, the trend since the 90s, 2000s is for correctional facilities, more so maybe in special units, for maximum security forensic hospitals, for state hospitals, for, the old developmental centers, now they're like maybe secure centers, is to do that. We have a program that you go to, classes every 45 minutes, every hour, different class, anger management, vocational training, vocational mentorship, being a good citizen, everything. So a lot of classes, and the treatment team meeting a lot. So I think there's an understanding. You can't provide that to everyone, especially in a correctional facility. That's very difficult to do. But you try to, as much as you can, take those people that really could benefit from that, either like a GED program at a minimum, or those who maybe have real mental illness or other needs, and pull them into these units and try to provide that. So that's been a trend, at least since like the 90s, to do that kind of stuff more and more. But something I think about in terms of trying to be realistic is that, when we talk about in different states the rates of mental illness, or individuals with going disabilities, there's still a very small percentage of overall, people that live in that state. So the amount of money that it takes to do those kind of special centers and the staff, and it really is staggering. Just to build a facility used to be, maybe this was in the 90s, like $65 million. So, and then you have all the staffing and the training and I'm just trying to be realistic in saying that, and I think that's important. You have to provide that. They're still citizens, they're people. You want to do, right by everyone. It's just the again, when you have everything happening within a state, and then you have like a small population of people that have maybe a lot of needs. I think in terms of state and politics, that gets to be really tough to balance that, to say, how do we balance all that? Because it takes money, unfortunately. So I try to understand that, to say, why does one system maybe get a tremendous amount of money to do something, another system maybe a little bit less, and it's easy to get into those kind of things. Why do they get so much money and they can do things? But it really is tough, and I think the things I've seen too also is that, for state income, you have, at one point, I think developing facilities may have been, especially correctional facilities, was an economy boost for different areas. Provided tremendous jobs, and and plus just the building, and it was a boost for different areas in the state where, they were really hurting. So, you have those kind of things rotate through these different areas and states where they need that kind of boost. So that, or maybe it could be a casino, all of a sudden, oh, a casino is going to be there and they're
Yeah.
closing down this facility. And so, the good thing was I wasn't involved in all that stuff.
Right.
Those are very horrendous, tough decisions to say, hey, we're going to boost that economy, but we're closing this facility and putting something else there. That's a tough decision. But so I think that, I think we kind of know what works in terms of an institution, and maybe who it really works for. But there was a high-level administrator in one system that once said, because people always complain, we're not doing this right, we're not doing that right. And she stood back, she says, I got to tell you, for 90% of the population of people that we provided services for, we're doing pretty good. They're waking up, they're safe, they have good quality of life, they feel satisfied, they're integrated in the community much more than they've ever been. Do we have that other 10% that we really struggle with? We do. And sometimes the struggle is big. And that, again, was a balance point for me to say, it's easy to look and say, oh, secure services, we need this and this, or correctional facilities, or the communication between, forensic hospitals, psych centers, correctional facilities, we need to do things different. But you don't hear about those kind of things as much, about how much, like even with the closing of facilities in terms of psych patients, there is some data that says that they're much more satisfied, they have better quality of life than being in an institution. And you got to be careful, because being in an institution too long, you become institutionalized.
Yeah.
Like the guy, remember the librarian in The Shawshank Redemption?
Yeah.
Right, he was a librarian for 40 years or something. And all of a sudden they're like, okay, that's it. You go out now, go have a good life. And he's like,
He goes and hangs himself. Yeah.
Yeah, that's an institutionalization. You feel like this is my life.
Yeah.
I don't know what it's like, imagine 40 years, you just popped into the future and you're saying, whoa. So you have to kind of be careful a little bit too. The longer you're in institutions where people kind of take care of you, and this, this procedure and structure and everything is what you just accommodate to, it does have a profound effect in terms of being institutionalized, where then you try to be more independent and have and figure out what a good life is for yourself. That does become tougher.
Yeah, absolutely. What I'm I have this statement, and I too am guilty of it, because I do it all too often, but it's, nothing is just black and white. Everybody can sit back on paper and you have, this is my opinion over here, and it's white, your opinion's black. But nobody ever takes the time to understand that there's that whole gray area in between, such as funding, such as just everything that goes involved with being short staffed. And I'm guilty of it too. I sit back and I'm like, well, I see the black side of things, where this all could be changed in the criminal justice system. And then I can see the part of the white side, but nobody really ever takes time to dissect and look at the gray area. And that was part of my reasoning for wanting to have you on here, because I think you can shed a lot more light into that gray area than even what I've taken the time to look at, or maybe what some of the other people that would be listening to the podcast would take a look at. Because there's, like you said, there's so many things that go into the criminal justice system and institutions and jails and so on and so forth, and it's this whole intricate system of just cogs and wheels and just movement, and nobody really takes the time to look at it. So
Yeah.
no, I'm glad I got to have you on, Dr. L. I'm pushing about an hour on your time, so I want to be respectful of your time.
Okay.
Anytime you want to come back on with a topic, man, you just shoot me an email. This was great. I think you have a lot of experience that myself and a lot of other people could benefit from.
Sure.
So if you ever want to come back on, I'll reach out to you. We'll set up another time and we could talk on another topic, or we'll go from there. But yeah, man, I really appreciate you coming on. You're a brilliant man. I appreciate your time and your expertise, and I appreciate all the years you put in the field, man. People like you are much needed.
Thank you. Thank you. You're very kind. Thank you for the opportunity. My wife thanks you too, that I'm not harassing her for this last hour. So she's very happy.
Hey, anytime I can be of assistance, let her know. We'll get you back on. No, my wife's the same way. She works from home and she's like, "Oh, you're busy at 10. Good. Bye. Get out of here."
Yeah. Same here. Yeah. Well, thank you. Thank you for the opportunity. It was a pleasure.
Yeah, absolutely. No, I'll reach back out to you. I've got all your contact info saved. And again, like I said, we will, if there's anything you want to talk about, something you think might be beneficial for people to hear, just shoot me a message. I'll have you back on whenever. I need more guys like you on here to kind of just smooth that gap, smooth that bridge, and help people understand, it's like I said, it's not black and white. So I appreciate you, Dr. L. And to everybody out there, we will check you next time, and see ya.
Adios.